Welcome to The Hidden Load for the educators and leaders in medicine who hold everyone up. We will tackle the hard topics and help you conquer your chaos and get to calm, all by starting to acknowledge and remove that hidden load. This podcast is a space for us to name the things that are common but not normal. Each week, we'll look at the invisible weight you're carrying and explore practical coaching-based tools to help you find more calm, better boundaries, and a sense of purpose that doesn't require you to run on empty. I'm so glad that you've carved time out for yourself today. Let's get into the episode. Welcome back to The Hidden Load. I am your host, Dr. Santina or Tina Wheat, and this is episode number 23, Medicine's Respect Gap, a hidden load for all specialties. Now, we have all heard the comments. Maybe it was a snide remark in the elevator about a soft admission, a joke in the break room about another department's work ethic, or even the backhanded compliment that a student is too smart for a certain field. In medicine, we often brush these off as locker room talk or just the way things are. But my guest today argues that these moments aren't just harmless jokes. They are part of a phenomenon called specialty disrespect. It is a hidden load that starts in medical school, but follows us through residency and into our lives as attendings and leaders. It erodes our teams, impacts patient safety, and fuels the fire of burnout. And to help me have this conversation, I am thrilled to welcome Dr. Jeff Weinfeld. Dr. Weinfeld is a professor of family medicine at the Georgetown University School of Medicine. He has over 25 years of experience teaching medical students and residents. He has held positions in quality and informatics for governmental, nonprofit, and community organizations, including working with HRSA's Office of Health Information Technology. He is board certified in family medicine and clinical informatics and practices at MedStar Family Medicine at Spring Valley in Northwest Washington, D.C. He received his medical degree from Boston University School of Medicine, completed his family medicine residency at the Georgetown University Providence Hospital Program, and received a master's degree in biomedical informatics from the Oregon Health and Science University. Welcome, Jeff. Thank you so much for joining us on this topic. As we get started, if you feel comfortable sharing, is there something that you have realized was a hidden load that you have experienced as an educator and leader in medicine?
Thanks, Santina. The hidden load that I'm going to talk about today is one that we've all experienced as family physicians, but one that really I didn't even have a name for until pretty recently. And in fact, many people in our field don't even know what to call it. So I came to identify this hidden load when I became the director of medical student education in our department. So I was, the leader who was responsible for helping to get students interested in family medicine and in advising students who are interested in family medicine. And students were all telling us that they were being actively discouraged by advisors from entering primary care fields, that they were being told, that they were too smart or even not smart enough for some competitive field, or that they would be paid too poorly or wouldn't be able to pay off student loans. And, we've all felt that uncomfortable feeling of knowing that as primary care doctors that we're so critical for the health system and for the health of our patients and for prevention, but that we're paid much less than some of our specialist colleagues, or that maybe we're having difficulty gaining privileges for some of the procedures that we're well trained for. And after experiencing this for a few years, I came across this paper by some family physicians at Penn State who described this as mistreatment based on specialty choice. And a bunch of light bulbs went off. And later came across another paper who described this phenomenon as specialty disrespect. And a little bit after seeing that paper, I formed a group in our department to start to look into it.
That is something that is so relatable to me. I think you just described half of the days that I have when I'm thinking of supporting residents and thinking about where they're going to work and how they get credentials, or some of the conversations that I have with students when they want to choose family medicine but are being turned away from it. And honestly, some of the things that I had myself when I was a medical student going through. Keeping that in mind, can you define what specialty disrespect actually is for us?
Sure, absolutely. So we use a definition from a paper that was published by someone named Alston And their definition is they call it one element of the hidden curriculum encompassing unwarranted, negative, and denigrating comments made by trainees and physicians about other specialties. So we most commonly hear about this, as it's experienced by students when they're expressing their interest in a specialty, and then they receive, negative comments about that specialty. But it could also occur as maybe a side comment from a specialist while you're admitting a patient, or, overhearing a comment that someone says in the ED, oh, this is a really soft admission, or that the admitting team or the PCP, did a bad job or doesn't know what they're doing and messed up. And then the patient gets admitted as a result. Or it could be jokes or snide comments, say made by surgeons about anesthesiologists. We've all heard those comments. And it's important to understand that this phenomenon does go by a lot of names. You might hear it called bad mouthing. That's kind of the words that they use in a lot of in UK and other Commonwealth countries, or specialty choice bullying, or it could be something more general like disrespectful or even just disruptive behavior.
I want to highlight something that you said in there briefly, that this is a part of the hidden curriculum. There are so many things that I think that are part of the hidden load that are because they are part of this hidden curriculum. I also just want to take a moment and pause and say, you and I are both family physicians. And so I think it's really important to say that this is not just a family physician issue, though. That's correct, that many specialties can experience this at different points.
Yeah, absolutely. So the group that we formed to look into this decided to do some scholarly work, and I'm really proud of the work that we did together. And we took a couple of years and were able to publish a scoping review, which was published last year in Medical Teacher. And we got a librarian and we looked for every article we could find on this topic. And we did, Medline searches and Embase searches and Google searches and looking at reference lists and all those fun things. And eventually we were able to find 83 articles that were published over multiple decades. And, when looked at it that way, like what articles have been published about specialty disrespect impacting various specialties, yes, we found articles that showed that many specialties were impacted. Even we found articles on like dermatology and certainly surgery and you name it. However, so many specialties are impacted, but when you look at the ones with the most articles published, yes, it was true that family medicine and psychiatry and GP in some of the Commonwealth countries and surgery were the most commonly mentioned in the articles that we found. If you want to look at it another way, like if you survey students and say, like, which specialties have you heard comments about? Again, some of the primary care specialties do also come out on top in that metrics. However, when you look at which specialties were the most respectful and also the most disrespected, some of those specialties are on both lists. So, you find that, specialties are both dishing it out, but also receiving it. And I think if we're honest with ourselves, we have also been sometimes disrespectful about other specialties in the past. So we're really kind of like all responsible.
I think that's a really interesting point. And I think that it's important to highlight that when we are increasing negativity in other places, that doesn't help us either. If we're trying to be sustainable in this career, it's important for us to be taking care of ourselves, but also those team members that we have to work with along the way. So I think this is an important thing to be bringing out in the open. And I know that I, as a student, definitely heard often, oh, you're too smart to go into family medicine. And then later, as an attending, I've had lots of conversations about my scope and the scope of my team members. What are some of the other ways that you have either experienced it yourself or seen it in the research?
I mean, probably the most significant issue is the impact on students. So some of the studies show that as many as 80% of students would experience specialty disrespect. And unfortunately, around a quarter of students actually change their specialty choice as a result, which is terrible. It also impacts the student-teacher relationship in a myriad of ways. So, for example, students are much less honest about what their potential specialty choices are because, well, they're afraid of getting graded more negatively, or they think it may impact their learning experience, right? That they may be offered different, let's say surgeries or learning experiences. And there's also a correlation between the frequency that people experience and its impact on mental health. Depending on the survey, it could be fellow students or residents or attendings who are most responsible for propagating those comments. But residents and attendings are also not immune to receiving those comments either. And I think it's fair to say that they experience those comments as, and as learners, and then we continue to experience them, throughout our careers, that there's just much less published research about residents and attendings. On the attending level, it's not hard to see how a disrespectful communication could create, poor communication, or even unsafe communication between people who are working together. Or if people don't feel comfortable or respected, they may be reluctant to speak up about safety issues or other concerns, and it can reduce, interprofessional communication. And then finally, the workforce. So we have an epidemic of burnout. And if students can't freely choose a specialty that they really feel passionately about, then maybe they end up in a field that they're not ultimately so happy with. And since we have this projected shortfall of primary care clinicians, we need to make sure that every student who wants to go into primary care, is able to do so.
I think that's so important because we talk a lot about the need to have more primary care physicians, as you just mentioned. And then I talk a lot about alignment, that it is much easier to be happy and sustain your career if you are aligned with the things that you love or with the things that are meaningful to you. And if we're pushing people into something else because it makes more money or because it looks like something that will look better on a CV or get them more accolades, if that's not what's meaningful for them, then we are absolutely setting people up for failure. Let's go back a little bit to that hidden curriculum. Tell me a little bit more about how you're seeing that as part of this.
Yeah, so the hidden curriculum is a really important concept, and we see the specialties track as part of that. So the hidden curriculum is, the curriculum that learners learn through either, observing the culture or kind of hearing messages informally. So that's kind of in contrast to the explicit curriculum, that we're taught in med school or residency. So, Krebs cycle explicit, that you might be in the bottom, of the totem pole and prestige in a particular field. That's hidden curriculum. So some examples might be like when junior students are told by senior students that they shouldn't go into primary care. So it could be something that's said, or it could be something that's more internalized. So many examples are something you might absorb, through the culture of medicine or the culture of an institution. They might see, differences in prestige between specialties, for example, or learn about differences in salaries between primary and specialty careers. They might see that a specialty, doesn't work at a particular hospital, and that sends subtle messages about the worth of that field.
I would add that I think you just talked about it a bit with students, but that continues also throughout your career, right? I think that even as someone who is maybe mid or later in their career, if they're thinking about leadership opportunities and they see that at a hospital only certain specialties are getting into those C-suites, and that might make them feel like they can't continue there as well. Or just even earlier on that you can't find a mentor to help you get there. So I talk a lot about educators and leaders. And so tell me a little bit about just that thing that I mentioned, how you see this hidden load, particularly for educators.
Yeah, so, as I think you pointed out, we are teachers and leaders, but we're also at the same time learners, and we absorb, various messages from the hidden curriculum. And I see the hidden load as part of the hidden curriculum, right? It's something that we learn and pick up, that these challenges, that you talk about as hidden loads, that those are okay. So like seeing that, working ourselves too hard is okay, or, in our discussion today, that it's okay to make jokes or put down other doctors and other specialty, that becomes, that we learn that it's okay and that we're supposed to just tolerate that as normal. Specialty disrespect itself, it is part of the hidden load. It is a hidden load. And furthermore, I actually think of it as a microaggression, right? We're used to hearing about racial or gender-based microaggressions. And of course, want to reaffirm the obvious that we want to work to end and fight all microaggressions. But, in his writing, Gerald Sue is one of the people who's written extensively about this concept, makes it clear that although we're used to these, hearing about racial and gender-based microaggressions, And microaggressions actually can happen towards any marginalized group. So in that regard, it fits the definition of a microaggression. And like all microaggressions, they take a toll on the recipient's well-being. So for us as family physicians, it makes us feel less valued in our health systems, or less than. It can make life in the hospital more difficult, a more difficult place to work, or potentially change the educational experience for our residents.
So obviously this is a problem. We've talked about what it is. We've talked about the impact it can have on the people who are being impacted by specialty disrespect, not to mention the patients who maybe don't get those physicians who chose not to go into those fields. So what do we do about this? How do we fight specialty disrespect?
Well, first of all, for any element of the hidden curriculum, the way to fight it is to name it and make it explicit. So when we talk about the hidden curriculum, publicly, we kind of make it visible and we can begin to name it and change it. So like at our school, we were able to create a specialty respect campaign that pointed out the issue itself and that various specialties were being stereotyped. And we created, pins and laptop stickers and a pledge, and you can take this specialty respect pledge too, and we can maybe link to it in the show notes. One of my colleagues helped to create a survey to document it at her institution. And so she did pre and post surveys, and we're hoping to publish the results to see, what was the impact of the campaign, because there's really very few, published reports about how people have tried to change specialty respect. On an individual level, when you encounter specialty disrespect, you can choose to respond in a similar way that you might respond to any other microaggressions. And again, let me start this discussion by saying that you might not feel comfortable speaking up, either in the moment or at all, and that's completely okay. There's typically going to be a power differential in many circumstances when you experience this, particularly if you're a student or a resident. So, the first part is to speak up, if and when, you're comfortable. This could be something that you do later or maybe by email if you feel comfortable using those types of communication. But if you decide to speak up, there's acronyms that you might have heard that you might want to follow. There's many different ones. The one that I like is called the action framework. So A is for ask, just to ask a clarifying question to help you understand someone's intentions, because sometimes they maybe are not what you're hearing. So I want to make sure I understand what you're saying. Were you saying that I would be wasting my career as a primary care clinician? C is a reminder to come from curiosity. I wonder if you're saying that being a primary care clinician is not worthwhile. T is for tell, to tell others what you observed and name it as a microaggression. I noticed that you haven't said similar things about other specialties, and this is a microaggression. I is to explore impact, to either ask for or state the potential impact of the comment, either on yourself or others. Well, that's really hard for me to hear because I'm excited about opportunities that family medicine would allow me. What do you think people would think when they hear this kind of comment? O is to own your own thoughts and feelings around the impact. When I feel your comment, I feel uncomfortable. And then N is to ask for next steps and request that appropriate action may be taken. So I hope that you can choose careers. I hope that we can all choose careers that are best suited for us. So hearing these comments make it really difficult for us to do that. I hope that you could refrain from such comments in the future.
I think that is a really helpful framework to be able to use. And I think that since we're talking to primarily educators and leaders in medicine, I think it's helpful to be able to share those tools with the students that you're mentoring or the team members that you're mentoring, the residents that you're mentoring, so that they feel like they have the ability to step up. I also have found it to be really helpful to say out loud about a lot of things to my teams, that there are times where they won't feel comfortable having conversations because of that power dynamic, and giving permission to bring them to me because I have a different power dynamic with other people. And so knowing that they have a safe place to land can also be helpful, I think, in one, acknowledging that we know that this happens and giving a pathway for dealing with it, because sometimes I feel like that helps. So thinking about it and individually, how else can we change our environment and work on this in a broader level?
Yeah, so on a broader level, our group has started to try to think about turning disrespect into respect. So we're trying to use that terminology. and think about, what does a respectful environment look like and how can we make that happen? We need to be really cognizant about avoiding specialty disrespect when we're interacting with students, particularly about specialty choice. And this kind of needs to become part of how we do counseling and how we train other advisors. And one thought that I find really helpful is, of course, we don't want disrespect, but like, what's the opposite of that, right? Maybe it's encouragement. So in counseling students, how can we encourage them to pursue the fields that they're really passionate about? So instead of dissuading a student from pursuing a particular specialty, can we provide factual information about our own specialty, using I statements about what we experience and what we've done, and avoid negative comments about other fields? Can we stimulate students to discover what they really want and not what others want? So there's a great article called 12 Tips for Having More Meaningful Conversations with Medical Students on Specialty Career Choice that has some of these and other suggestions. I highly recommend that. Again, we could link to that in show notes. So in working with colleagues, the research suggests that a lot of disrespect arises from lack of knowledge. And then when there's a gap in knowledge, then stereotypes kind of set in. So that leads to misinformation. For me, I think, when I know someone individually, it's much harder to be disrespectful, and the opposite way around. So I think it's really important to get to know your specialty colleagues. I really miss that old physicians lounge where we used to bump into each other organically and, people could get to know each other. But, you can still interact with colleagues in a professional setting. You can invite them to practice meetings, to speak, to provide CMEs, to residents or attendings. You can invite them out for a coffee. And I think another really simple thing is to use names in chart notes and referrals and other communications instead of the generic, your neurology said this, as we often have these kind of like generic, discussions in our notes. And, I know it really can be hard, but, sometimes when you hear a comment, it's not what you think. And so we should initially at least assume the best. Sometimes, a certain comment may seem not respectful, but in asking for clarification, you might find, a totally different thing. So one time I ordered a biopsy in our EHR and received a very terse inbox message saying this was a 2 radiology. So I got a note back from radiology. It wasn't even from the doctor. It was from, I don't know, a receptionist or someone who wasn't the decision maker saying that it wasn't needed. And I was like, what? This doesn't make any sense. And I was kind of floored, but I asked to speak to the radiologist and we got in contact, and it turned out that the radiologist had actually gone out of their way to review outside films, not even just our films, but other ones, and reviewed and compared and gave it, thought and attention, and actually had information that we didn't have, and we were able to have a really good, respectful conversation. And the patient ended up getting better care because of all that. But it just was that communication didn't really come across in the context of the EHR, which is, maybe not the best communication medium. So for institutions, this is kind of takes it up another level. We really need to insist on respectful environments that are free of specialty disrespect. And that's really for ourselves and for our learners. A lot of places have found it really impactful to do a survey locally. We have plenty of literature that shows that this exists, but it's much more impactful when you're like, hey, our student said this. So that can be really impactful as a way to kind of get people to realize that change is necessary. You can share articles, you can share our articles, our materials, you can hold grand rounds and ask for change. If you work in a medical school environment, the AAMC has questionnaires, the GQ and the Y2Q Year 2 questionnaire, and they have questions within those surveys that ask about specialty disrespect, and you can point to those items and compare them to national norms. And then kind of going up another level, our national organizations, I think those organizations really need to speak out and call for an end to this as well. We can't tolerate this nationally and between doctors and society or between organizations. And, it ends up creating these microaggressions, that do damage to our learners and colleagues and contribute to burnout. And then, we need to have really even an even broader conversation, in society about the pay and prestige of primary care. These are some of the underlying issues that create disrespect and create these differences. And so if we can't fix these underlying issues, then we won't have enough family physicians and pediatricians really to take care of our population.
Jeff, you just gave us so much. So I just put some of the highlights from that is to find out more information about what's happening at your institution in your setting, to have connection, which we also know is so important in so many things. I think that's one of the things that we've lost with COVID, making things so virtual. We've lost some of that in-person connection. Picking up the phone, I think, is one that you just said, which was great. And sometimes those EMR messages just come across as terse. I'm definitely guilty of that myself. I'm doing everything I can to be efficient. And when people don't know me, they don't know that there's somebody else behind that. So picking up the phone is important. And then I think that having the common conversations with our professional organizations, with the educational organizations, and really having transparency about this being a problem and that we need all of us. We really do need all specialties to make healthcare work and to continue to advocate for payment and payment reform that makes sense for all specialties. We don't want to take away from certain people, but we do want to make sure that we're valuing all of the hard work that's happening, including of the cognitive specialties, which we know are just paid less than some of the procedural specialties. That is a lot to be able to advocate for and move forward in. Jeff, I have one extra question for you, and that is, as you've done all this research on specialty disrespect, I know that you said it was sort of an aha moment when you saw the term, when you saw it all coming together. Is there something that you wish you would have realized sooner in your career that might have made it helpful?
I think for me, it was just that then being able to name it and understand it and know that this is something that's just been going on, since specialties were a thing. It's been going on, but again, it's when you name part of the hidden curriculum, then you can start to understand it. You can start to change it, and that was super, super powerful. And I think that enabled us to move forward in some of this work. And I hope that other people can see that it's a problem, and that we can begin to get some change, locally and also in the broader national sphere.
Absolutely. I think that naming things is always the first step, because when there's awareness, we can start to change it. We can do something about it.
Totally.
So, Jeff, I think this has been really helpful. If people would like to get in touch with you or to find some of the resources that you've mentioned, I'll, of course, add some of this to our show notes, but how can they get in touch with you?
So I am on LinkedIn, Jeff Weinfeld, and on X as Jeff Weinfeld as well. And we'll put our article and our website and some of the other resources into the show notes.
Great. And if people are interested in collaborating with you on this work, maybe at their institutions to do cross-institution work, are you open to that?
Absolutely. In fact, we have a specialty respect community of practice, and we can put that information to. We meet quarterly and have presentations and discussions, and have a number of collaborations with people in various fields and within family medicine as well.
That sounds amazing. Thank you so much for joining us today, Jeff. I think this has been a really enlightening conversation, and I hope it allows people to think about some of the comments that are happening, even if they're unintentional, and the impact that they can have for our learners, our teams, and each other. Thank you.
Thank you.
I want to thank Dr. Jeff Weinfeld again for joining us today and for the incredible work that he is doing to put a name to something so many of us have felt but haven't always known how to fight. As we wrap up, I am struck by the idea that specialty disrespect is not just a family medicine problem or even a student problem. It is in reality a professionalism problem. Every time we allow a snide comment to go unchecked, or we stay silent when a colleague's expertise is questioned, we add to the hidden load that makes medicine harder than it needs to be. But as leaders and educators, we have the power to change the narrative. By choosing curiosity over contempt, and by explicitly teaching respect as part of our curriculum, we don't just help our students, we improve the environment for ourselves and for our patients too. And so this week, I challenge you to take one small step towards bridging the respect gap. I want you to audit your own language. Are you using names instead of just the service in your notes? I want you to speak up. If you hear a microaggression in the wards or the boardroom, then use that action framework that Jeff shared with us. And connect. Reach out to a colleague in a different specialty just to learn more about their world. You can find all the resources mentioned today, including the Specialty Respect Pledge, in our show notes. Thank you for listening to The Hidden Load. Let's keep working to make the load a little lighter for each other. And we'll see you in the next episode.
Thank you for listening to The Hidden Load. If today's conversation spoke to you, I would love for you to share it with a colleague who might need to hear it too. It's one of the simplest ways we can start shifting the culture of medicine together. And remember, your time spent reflecting here matters. You can earn free CME or CE credits for listening to today's episode through the Pinnacle app. You'll find that link in the show notes. If you are looking for one-on-one coaching support or want to dive deeper into the resources we discussed today, let's connect. You can find information on how to reach me in the show notes. And don't forget to hit subscribe so that you never miss an episode. And leave me a rating so that others can find me too. And take care of yourself because you deserve to be held up too. And I'll see you next time.